radiodiagnosis, CMC Vellore. She was previously the president of Cyclone, and she is a sort of the speaker for many conferences and apart
in the talk. And residents, please shout out answers to make it interactive. So let's start out with the case. Have a look at these images. 65-year-old. There is some kind of smoking history, and there is a long history of breathlessness. So what do we see on the images? So there is honeycombing with a basal predominance. So the question here is, how do we interpret this? Should we say there is an ILD? Should we say there is some kind of fibrosing ILD, UIP pattern? Should we say there is idiopathic pulmonary fibrosis? We saw the history of smoking. Should we say it is an NSIP pattern? Residents, what should we say? Option number 2. So we will be saying it's a fibrosing interstitial lung disease. How do we say fibrosis? Will come to it. And we use the term pattern in radiology or pathology because we don't know the whole picture. Only after we make sure that there's no underlying cause, then we come to the diagnosis of IPF. So it's better to use the terms UIP pattern or NSIP pattern, the word as a pattern, to say that we are describing the HRCT findings and not actually the clinical syndrome. So we know UIP pattern can be seen in many conditions, including CTD, ILDs. Even in hypersensitivity, you can get a UIP-like pattern. What do you think this patient is having? This is a Hermansky-Pudlak syndrome. How are we saying that? So he had UIP on his CT, and basically is having this. He had oculo also. I've just masked it, but basically oculocutaneous albinism. So the combination together is the Hermansky-Pudlak syndrome. So UIP pattern can be seen in many conditions. So what are the hallmarks of fibrosis on a HRCT? So basically what we see as reticulations. What are reticulations? They are just this network-like thickening of the interstitium, which can be the intralobular, interlobular. All the interstitium is thickening and giving rise to a network-like thing, just extra lines. That is the reticulations. Then this traction bronchiectasis. So in addition to that, the bronchi are getting dilated because of this fibrosis pulling the bronchi. And the honeycombing. These are the hallmarks of fibrosis. So when we see any of these, we can say there is a fibrosing component to this disease. And honeycombing is the hallmark of the UIP pattern. So what is honeycombing? It is multiple layers of these cysts which are kind of uniform in size. They share their wall and the wall is slightly thick. So this is a typical appearance of honeycombing. But we should not confuse honeycombing with paraseptal emphysema or cysts. So this is a patient with cysts. So these are not really sharing walls. They are multiple cysts scattered. And this is an example of a paraseptal emphysema. So we should not confuse these to be honeycombing. And another entity is this airspace enlargement with fibrosis, which again we can confuse to be honeycombing. So what is this? This is basically like emphysematous changes with little bit of fibrosis, but they don't have much of traction bronchiectasis associated, and these air spaces are much larger than the honeycomb cysts. So these are the things that we should not confuse for honeycombing. So what does this patient have? He is a smoker. In the upper lobes, what do we see? There is paraseptal emphysema, and in the lower lobes we do see honeycombing in addition to the emphysematous bullae. So what is this entity? CPFE, or combined pulmonary fibrosis and emphysema. So that brings us to the when do we diagnose this UIP pattern? So everyone is familiar with this table. This is the more recent update of IPF and PPF from the 80s. So how do we say UIP pattern? When we see there is subpleural basal predominant honeycombing, as we saw in our index patient, it is usually having that heterogeneity, and there can be all these reticulations, traction bronchiectasis, etc. Similar subpleural basal predominance with traction bronchiectasis and reticulations indicating fibrosis, but without the honeycombing, then we cannot confidently make the state it as UIP pattern. Then we will say it is probable UIP pattern. When it is not clear cut, just some reticulations and minimal traction, then we'll say it's indeterminate. And they also give this alternate diagnosis when we see certain other conditions like lot of cysts, lot of mosaic attenuation, lot of ground glass densities. All these should make us think of alternate pathologies. So let us look at some examples. So this is a typical UIP pattern where we can confidently say based on the honeycombing. Here there is traction bronchiectasis and reticulations, and here there's just a little bit of reticulations. So here what do we see? There is again a UIP pattern based on the honeycombing, but we see that the esophagus is markedly dilated. So this was a CTD or a scleroderma patient who is having a UIP pattern. So then it is a CTD ILD with an UIP pattern. So there are some signs which have been described for the CTD ILD, which is exuberant honeycombing, excessive honeycombing. The straight edge sign, that is in the lower lobes, the differentiation between the area of fibrosis and normal lung on the coronals looks like a straight edge. That is also supposed to be one sign of CTD ILD. And this four corners or anterior upper lobe, involvement of small areas of fibrosis and honeycombing in the anterior upper lobe. All these are supposed to be more common in CTD ILDs. So this was a patient, she was 45-year-old. Young age lady. All this also will bring up our antenna for CTD, and we saw this very excessive honeycombing, almost like a straight edge, and these islands of fibrosis anteriorly in the upper lobe. So we thought this could be a CTD ILD. There was no esophageal dilatation. She did not have any CTD symptoms, but on the workup, the dermatomyositis profile was strongly positive. So that makes us finally, with the MDT diagnosis, was like an IPAF or pneumonitis with autoimmune features. So basically there are autoimmune features, but it's not diagnostic of CTD. So the common patterns that are seen in IPAF will be like this: organizing pneumonia or NSIP. I think this, we'll just skip this. Yeah. So basically other importance of radiology is to follow up these patients and see whether there is any worsening of the fibrosis over time, or they can develop acute exacerbations. So we can see that the fibrosis has also mildly increased with larger size of the cyst, and we can see that there is development of ground glass densities, which could be due to an acute exacerbation. So there are diagnostic criteria set up. So basically newer radiology with when we rule out other causes like infections. What is the diagnosis in this patient? What do we see here? There is honeycombing, which is lower lobe and basal predominant. So it is like an UIP pattern. Is there anything else that we are seeing here? There is an effusion, yes, and there is also a mass. So these patients are also prone for malignancy, so we should keep looking for any development of nodules or malignancy in patients with UIP or IPF. So let's look at the next case. So what do we see here? So we see ground glass, we see little bit of reticulations, not much of traction, there is no honeycombing. And if you look at the immediate subpleural area, that is mildly spared. So it is more central, but it is having an apicobasal gradient, but it is little more central with immediate subpleural sparing. Also, what is this? The esophagus is dilated. So what is the diagnosis now? It is a CTD ILD. Why are we saying that? Because we are seeing that the esophagus is dilated, likely to be like a esophageal dysmotility. And what is the pattern here? It is an NSIP pattern. So what is the typical things of NSIP pattern? There's a lot of ground glass. It's more central. with immediate subpleural sparing. But immediate subpleural sparing is not seen always. It may be seen in like 40-50% patients. So absence of subpleural sparing does not exclude NSIP, but if it is there, that helps us to say that it is likely to be NSIP. So NSIP pattern again can be seen in CTD, can be seen, this is a drug-induced bleomycin, patient was on bleomycin. In various conditions can give NSIP pattern, and if there is no cause, then we can say it is an idiopathic NSIP. Let's go to the next case. What do we see here? What is the main thing that we are seeing is multiple nodules. So once we see nodules, how do we approach that? We need to say where the nodules are distributed. What do you all want to say? What is the distribution? Sorry, I can't hear. Central lobula. Yeah, okay. Ground, yeah, the density of the nodules is ground glass, correct? But the distribution is central lobula. So how do we say it is central lobula? We are seeing all evenly spaced nodules, and they are just away from the pleura, and some of them are almost having like a branching kind of appearance. So once we see this profuse nodules, it is like an alternate diagnosis in that IPF paper if we see. So how do we approach the nodules? First thing is we look at the pleura and fissures. Are there nodules there or not? If yes, is it predominantly along the pleura and fissures? If yes, it is a perilymphatic distribution, and the typical things that we know are the sarcoidosis and lymphangitis. If there are few nodules along pleura and fissures, but it's not predominantly there, it's all over the place, then it is mainly a random distribution. Whereas if there are no nodules along the pleura and fissures, like we saw in our previous case, it is a central lobular distribution, which we know can be seen in hypersensitivity, respiratory bronchiolitis, and also infections like TB. So again, what is the distribution? Look at the pleura. Are there nodules along the pleura? No, they are just away from the pleura, just separated from the pleura. So this is a central lobular pattern, and they are ground glass density nodules. And if I say a patient has pigeons in the house, what is this? It is a hypersensitivity pneumonitis, all right? Non-fibrotic. We didn't see any fibrosis, we're just seeing the central lobular ground glass density nodules. Similar pattern, but little less obvious, but we can see faintly some nodules here. So this was a smoker and respiratory bronchiolitis. What about this? Again, we're seeing lot of nodules. How is the distribution? Are we seeing nodules along the pleura and fissures? Yes. Is it predominantly there or all over? Predominantly along the fissures and along the pleura. So this is what is the distribution? Perilymphatic, right? So what is the diagnosis? Sarcoidosis. So perilymphatic nodules in sarcoidosis. Other things like lymphangitis can also give that appearance. What is this? Again, we are seeing lymphadenopathy, and we are seeing lot of nodules, little bit along the fissures, but mainly here what we are seeing along the peribronchovascular. So that is also the central interstitium. So peribronchovascular nodules. So here we are seeing nodules along the bronchi. So peribronchial nodules, and here perivascular. So all these are examples of perilymphatic nodules: peribronchovascular, perifissural, and subpleural. What about this patient? What we are seeing here is mainly like a mosaic attenuation. So we are having higher density areas, we are having low density areas, and some reticulations, little bit of fibrosis. So mosaic attenuation, again, alternate diagnosis we need to think of. And what is this pattern called? What is this sign called? It's called as the 3 density sign. So what are the 3 densities? There is normal lung, there is ground glass density, and there are areas of air trapping. So those are the 3 densities, and this air trapping can have this lobular shape, like the shape of the secondary pulmonary lobule. And previously same thing was described as head cheese appearance, but now the preferred terminology is the 3 density sign. So that brings us to the where we see the 3 density sign is a hypersensitivity pneumonitis. Previously we had acute, subacute, chronic, and now the preferred classification is fibrotic and non-fibrotic. So this was an older gentleman who was working in the cattle fodder making factory. So let's have a look at this. So what are we seeing in the upper lobes? What is all this? Honeycombing, right? Honeycombing, lot of reticulations, honeycombing. So what are we saying? Already we are starting to see that there is lot of fibrosis, right? So this is, honeycombing is the hallmark of fibrosis, we said. So there is honeycombing. It's starting in the upper lobes itself. So a lot of honeycombing in the upper lobes. And we are also seeing these small areas of like air trapping. Some little bit of ground glass, not much of ground glass, mainly it is honeycombing. And as we come to the lower lobes, there is less amount of fibrosis compared to the upper lobes. Again, we are seeing some areas of like air trapping, and we are starting to see like the 3 density sign in the lower lobes, where we are seeing normal ground glass and air trapping. So this is a very typical appearance of a fibrotic hypersensitivity pneumonitis. So I'm sure you'll go through all these, you have sessions for everything. So basically again, this has been classified as typical, compatible, indeterminate, etc. for fibrotic HB. This is a patient with pigeon exposure. What do we see here? We are seeing ground glass, and again this lobular kind of areas of air trapping. So this is, and there is not much of fibrosis. So this is a non-fibrotic hypersensitivity pneumonitis. Again, we have the typical and compatible in that. You will be going through this, so I'm not going into details. But just want to stress one point. For hypersensitivity, we need to look at, we need to show that there is parenchymal involvement as well as airway involvement. So parenchymal involvement, we will be showing by the mosaic attenuation or the ground glass densities that we need to see. And the airway involvement, we will be demonstrating based on the central lobular ground glass density nodules that we saw or the air trapping. So we need to have both to make the diagnosis of the hypersensitivity pneumonitis. Okay, next case. So what do we see here? Let me describe. So basically, what is all this? There is honeycombing, right? And is there an apicobasal gradient? Yes. So what is the pattern here? UIP, probable UIP, indeterminate, alternate diagnosis. At first look, it looks like UIP, right? But let me just draw your attention to these things. What are these? They are pleural plaques. So multiple pleural plaques are there, and this one is almost calcified. Sorry, I didn't put the mediastinal window. So now what does it make it? Basically, calcified pleural plaques are there along with the fibrosis and honeycombing. So this is alternate diagnosis. Why? Yeah, sorry, here is the calcified plaque on this image. So when we see pleural plaques, mediastinal finding, dilated esophagus, all this is alternate diagnosis. So what is the diagnosis basically? Asbestosis. So this is asbestosis. What about this one? So basically is a smoker. Lot of ground glass opacities, some cysts are there. So we can think of, when there is lot of ground glass opacities, again it is an alternate diagnosis, and this is an example of a DIP or desquamative interstitial pneumonia. So what do we see here? There are multiple cysts, and this one, if you see some of these, they are having the typical perivascular distribution around the vessels. There are also small ground glass density nodules kind of areas here. So this kind of perivascular cyst typically described in LIP or lymphoid interstitial pneumonia. We know that it can again be idiopathic or can be associated with Sjogren's or HIV. So again we'll see other examples of cystic diseases. This is a young woman, and this is a male smoker. So what is this? LAM, that is multiple cysts, diffusely distributed, intervening lung is normal, can be seen in LAM or lymphangioliomatosis, we have to look for association with tuberous sclerosis in these patients. So young male smoker, there is also a pneumothorax, irregular bizarre shaped cyst, that is LCH or histiocytosis. They can have a nodular form which later cavitates and forms a cyst. Again, we should be clear to differentiate cysts from emphysema. So cysts have thin walls, whereas emphysema, this is the centrilobular emphysema, there's no perceptible wall to it, and in the center of the centrilobular emphysema we see the centrilobular vessels. So that is how we try to differentiate between emphysema and cysts. Next case. So the question is, which of this is not a differential? What is the main finding? How do we describe this? They are areas of consolidation, right? These are areas of consolidation distributed predominantly in a, where are they? Peripheral or central? Is it subpleural or peribronchovascular? Peripheral, right? So basically it's multifocal consolidation distributed peripherally. So all of these can give, except the UIP. It's not, obviously not the UIP pattern, right? Any of these can give peripheral consolidations. Eosinophilic pneumonia, organizing pneumonia, vasculitis, all these can give peripheral consolidations. So in this patient, it was organizing pneumonia. So again, that comes under the alternate. So organizing pneumonia, we know, can again be idiopathic or can be secondary to infections, drugs, whatever, any lot of conditions can cause organizing pneumonia. And this is a very typical example and typical sign. What is this sign? Yes, atoll sign or reverse halo sign, where there is central ground glass density with a halo of consolidation around it. Again, it was typically first described for hypersensitivity, but it can be seen in many other conditions, including TB, etc. But once we see it, we should definitely think of organizing pneumonia. So organizing pneumonia typically can have bronchocentric or subpleural predominant patchy consolidations, and they can be fleeting if we follow them up. They can be migratory or fleeting kind of consolidations. Rarely it can have mass-like appearance, which obviously we cannot diagnose on imaging. We have to biopsy. And sometimes it can be associated with interstitial pneumonia. So there may be an NSIP-OP overlap kind of pattern. Rarely they can have nodules, etc. This is another thing that should make us think of organizing pneumonia, this arcade-like appearance of consolidations or perilobular distribution. See, this is like a shape of a secondary pulmonary lobule with consolidation having a perilobular distribution. So perilobular, arcade-like, reverse halo, all this should suggest organizing pneumonia. So what is the pattern? Basically here we are seeing diffuse ground glass density, very extensive with no underlying cause. Then we call it acute interstitial pneumonia. And basically the pathology is same as ARDS as we know. What about this case? What do we see here? Are we seeing any fibrosis? Are we seeing any features of fibrosis? So what did we say were the features of fibrosis? Either reticulations, traction bronchiectasis, or honeycombing. Are we seeing any of those? Are there reticulations? Yes. Is there a little bit of honeycombing? Yes. Is there traction bronchiectasis? Yes. So there is fibrosis, but what is striking here is, where is the distribution? Is it in the upper lobes or lower lobes? It's more in the upper lobes. And can you see the adjacent pleura is also showing thickening. So this is an example of pleuroparenchymal fibroelastosis. Again, it's alternate diagnosis mainly because it is the opposite pattern than UIP, where there is predominant upper lobe fibrosis here. So this was pleuroparenchymal fibroelastosis. So when we see fibrosis along with adjacent pleural thickening and predominant upper lobe involvement. Now what entity are we coming to? So basically what are we seeing? Baseline 3 years, 5 years, there is progressive worsening in the fibrosis. How do we see there is progressive worsening? Increasing honeycombing is happening over the years. So what is this condition? It is basically progressive pulmonary fibrosis or ILD with progression. So we all know that IPF is the hallmark, is the one which is supposed to have relentless progression. But any of the ILDs, whatever sir said, the various classification, any of them can go into progressive fibrosis. So this table also everyone is familiar. So some of them have higher chance of going into fibrosis, whereas others have less chance of going into fibrosis. So we know how we diagnose it. Basically, they should be worsening in any two of the three, that is either clinical or physiological or radiological. So let me say what are the radiological evidence of progressive fibrosis. One is, if there is just presence of ground glass density, it does not say progressive fibrosis. New ground glass with reticulation or with traction bronchiectasis, then only we can, that is one of the sign of progressive fibrosis. New or more coarsened appearance of the whatever reticulation that was there, increasing extent or severity of the traction bronchiectasis, new or increased extent of honeycombing, or increasing volume loss. Basically, whatever we said is fibrosis, if any of it is new or increasing, then if any one of these is there, we can say there is radiological progression. So some examples. So here we see it's mainly ground glass density, which later, sorry I don't have HRCT at this point, so it's a little blurred, but later the same areas, the ground glass has reduced, but there's a lot of traction bronchiectasis and early honeycombing also developing. So this is definite progression radiologically. Similarly, here we can see that the reticulations have become more coarse. The honeycomb areas have become larger. There's increase in the size of the honeycombing. So this is also progression based on radiology. Again, we see, look at the size of the traction bronchiectasis here and see the size. So again, this is a radiological progression. This was a patient with scleroderma. See the marked dilatation of the esophagus. But basically, scleroderma ILD or CTD ILD can also go into progressive fibrosis, and this is radiologically progressive fibrosis. So we can quantify this fibrosis just visually, or they can be, we can do it computerized thing where lung texture analysis can be done and quantitative scoring can also be done. A small note about interstitial lung abnormalities. So we know that this is a newer terminologies that we keep using. So what is ILA or interstitial lung abnormality? When we see some interstitial opacities on a HRCT or CT done for any other cause. So we are not really suspecting an ILD. So if it is say a known CTD patient and we are doing HRCT to look for ILD and we see some ground glass or something, then we cannot call it as ILD. We cannot call it as ILA, we have to call it as ILD itself. So ILA is where we are not actually suspecting clinically and we are just radiologically seeing some findings. So there are different things, and some of these can also go into fibrosis and they can be kept on follow-up. So extra pulmonary findings also we need to look for. So we just mainly saw all the pulmonary findings. So if we see adenopathy, we can start thinking of sarcoidosis. If we see pleural plaques, we think of asbestosis, etc. And complications, again to look for pulmonary hypertension, when the pulmonary artery size is more than 29 millimeters or pulmonary artery to aorta size more than 1. Any RA-RV dilatation, again indicating pulmonary hypertension. Other complications like malignancies, superadded infection, acute exacerbations, all these we need to look for. The protocol we need to follow very strictly. So by definition, we need to say it's less than 1.5 millimeters in thickness. And inspiratory, expiratory, prone images as necessary, we need to do all this. And the reconstruction has to be done in this high spatial frequency algorithm. Just a very short recap. Yeah, we have time. A, what is this? Distribution? I think now everyone can answer, please. Are there nodules along the fissure? See this? See here? See some here? So there are some nodules along the fissure and pleura, but are they predominantly there or are they all over? All over. So this is random. Excellent. So this is random distribution. B, peribronchial, right? So this is, what is the distribution? Perilymphatic. What about this one? Yeah, see, they are in the center of the cell. It's all equidistant to each other, just away from the pleura. So central lobular ground glass density nodules, typically in hypersensitivity pneumonitis. What about this? I did not show you an example, now only I am showing. Basically there are multiple nodules, they are forming clusters. So this is a TB or sarcoid. Any of these can give this sarcoid cluster or TB cluster, okay? What about this? What is there on the X-ray? Lymphadenopathy. What is there on the CT? See, perivascular nodules. So what is it? Sarcoidosis. So lymphadenopathy and perilymphatic nodules, sarcoidosis. What about this? We already saw this, yeah? CPFE. CPFE, so emphysema, bullae in the upper lobes and honeycombing in the lower lobes, so CPFE. This is honeycombing, so this is the UIP pattern. B is the probable UIP and C is the indeterminate. What about this? This is the clue here. Esophagus is dilated, so it has to be a CTD. So what is the pattern of ILD here? Mainly what are we seeing? Mainly it's ground glass density. Little bit of fibrosis is also there, but lot of ground glass density is there. So we can call it as an NSIP pattern in a CTD ILD or scleroderma related NSIP. What about this? Hypersensitivity pneumonitis. So we are seeing central lobular ground glass nodules, and here what are we seeing? 3 density signs. So hypersensitivity pneumonitis. So just some take home points. UIP pattern, once we see on CT, we just need to do the multidisciplinary meeting just to look for any underlying cause, but we don't need to biopsy. Once we see typical UIP pattern with no cause, we can diagnose IPF. But if it is probable UIP indeterminate or any of the other diagnoses, we may need biopsy based on the discussion. And once we see this 3 density sign, the lobular areas of air trapping and the central lobular nodules, it's very suggestive for hypersensitivity pneumonitis. So just to stress that the multidisciplinary discussion is important in all the ILD diagnosis. Thank you.
Thank you, Aparna, for the lucid presentation talking about the patterns of ILD and how radiology helps in bringing the final diagnosis. For want of time, we can take 2 questions open to the floor.
Good morning, ma'am. Thank you for your nice presentation. I have just 2 questions, basic questions which we see for all our ILD patients. The first is, for the UIP pattern of a honeycombing to describe, do we need to have now multi-layered honeycomb cyst, or can it be in the single layer? Second question is, esophageal dilatation. At what location we should see, like below the ventricles, or like what location? Sometimes in HRCT mediastinal window we see high up esophagus also. And my third question is the lobular air trapping you told about. How many areas they should be involved? Because nowadays I think concept of coming more than 5 lobular areas in both the lungs. So what is that concept and where we need to look at that? Thank you, ma'am.
Thank you. Yeah, so let's answer one by one. The first one was single versus multi-layered. So the typical description of honeycombing is that it is multi-layered, but nowadays more and more people are saying it need not be multi-layered. Even the single layer can be taken as honeycombing, and we have seen through the things some examples where it may be just as 1 or 2 layers. It may not, when it is too much and exuberant, we see all these multi-layers. So it does not always have to be multi-layered. But we need to see other findings suggesting fibrosis, like the traction bronchiectasis, etc., that to add to that. Second question was about the esophageal dilatation. So usually what happens is this is a esophageal dysmotility. So the entire esophagus will be dilated. So is there a cutoff, like when do you say it's dilated? So some people say 18 millimeters, but I don't think any of us is actually sitting and measuring the esophagus. It is a visual thing, and it is usually the whole esophagus which is dilated. If it is just one small segment which looks a little dilated, may not be significant because maybe it's some peristalsis or something. So usually it's the entire esophagus. What was the third question? Sorry. Lobular air trapping, yeah. So again, basically these are diffuse diseases, right? So it is usually diffusely seen. So, and we're not going to make a diagnosis based on one focus of air trapping or anything. We are just going to look for a diffuse disease, right?
Thank you, Aparna.
Any more questions?
Regarding this esophageal dilatation, it's not pathology, but one should see that, then instead of living directly in IPF, should start thinking that there is some secondary. That is the only. Otherwise, a CT scan, all the